Thank you. So, just so we can read the slides as well, let's not go that way. What I'll say from the beginning is hello, welcome, we're really excited to be talking to you about this. We've got about 30 minutes, but do stop us at any point if you've got questions, queries, challenges, keep those low. Is that okay? So, down, what slide was?
Sorry, save this.
Oh, there we go. So we're going to describe to you on one slide where we started. Some of these places might be resonant for you. I've spoken to a few of you already at break this morning. We're going to talk about our civics complexity framework. We may get to some of the data I gathered about it, very basic doctor data, everybody, not big numbers but fine numbers, and our future plans. And what we're hoping today will enable us to talk about and to think this afternoon together about what complexity looks like, what working with complexity could be like, and how we might deliver care to patients in the community. So if you ask me to say what the tin label was, complexity framework describes what we do, what we do as a community team, 7 days a week, 9 to 5, and a bit of thinking outside of that. Is that okay? So where we started, a few years back now, 3, 4, I came to join St Luke's, and St Luke's invested in consultant time, but still there were a limited number of sessions. And one of the key sets of learning, I suppose, in other settings I've been in, is everyone has an opinion about what the consultant should do, what the senior team member should do, where you should see patients, how to see patients, which ones you should see. We also had within the team, Joe Lecco, we had variance in skill set and knowledge. We talked about doctors and nurses. We had what you might politely describe as a siloed professional approach. So you might have people who visit people every 2 weeks. So you might have a consultant timetable which is set in stone. There's that kind of multidisciplinary difference there. We have no method, as Joe is pointing out to me, of describing rapidly changing complexity, certainly in the community. We had different ways of communicating within the team and with other people outside of us. We had several versions of letters and several ways of doing that, and several time ways of doing that as well. We also have a mixed approach to communicating in MDT, as you've heard described, and we really didn't have equitable access to 7-day service. So at the beginning we'd start to see people more intensively, and then it got to Friday, and there was no good to continue to see people intensively. Okay. So we had some very early learning. So we took what we thought the doctors and senior nurses should go and see. Joe did a rapid response trial. Go on.
Yes, it's kind of like, yeah. I did that about 3 years ago. We introduced what we call the rapid response team, and that was where we identified, it was only me who started it, and I think for the first month that I did it, I think I did 84 visits on my own, and that were purely all urgent referrals. That I soon realised I needed more than just me to do that. I dealt with all the urgent referrals that came into the team, and was able, surprisingly, to be able to offer same day or next day face-to-face assessment, and that really sort of shaped and transformed and has helped us deliver the care that we're delivering today.
So before we proposed amazing suite of measures, which was in the middle section, we had to start to describe to ourselves what we thought the complex situations. Does that make sense? So we had complex therapeutics, which was the medicines management, they were prescribing, it was the bowel obstruction. We had some types of care emergencies which we identified, and advanced care planning, so the complex best interest meeting, sometimes patient with no ADRT who was in a nursing home about to go for an ambulance baby, all facts. Okay, so we were able to describe some broad themes. In the early days, part of that, I talked about that first time about communication, didn't I? SBAR handovers. We've got the team member who hasn't experienced acute medicine or changing handovers recently. The SBAR handovers are really key moment for us, just enabling people to shorten down their descriptions and get to salient points. And 7-day work is what we introduced, and that enabled us then to have a bit more flow and in the team. Sam and Julie from the university described a new MDT. It's looked really easy, isn't it? We have a new MDT, we implemented the executive measures, but we did have our own complexity framework version which we incorporated new MDT. We used delegation, which we talked about briefly. We also started to talk broadly together. So a morning huddle for the rapid response team and medics, like what was going to happen that day with those complex patients that we knew about, and also the very urgent referrals that we had, who was going where. And we also talk a little bit about flexible diaries. Okay. So
Did you want to ask a question? So I think as part of just going back to what rapid response wasn't just about how we worked, for me it was about what difference it made to that patient at home, having that daily intervention, having that twice daily intervention. Did it save hospital admissions? Did we get their symptoms under control? So we'll talk a little bit quicker. So we'll talk about that a little bit more. But the complexity framework also, it describes how we case find and case manage complex patients. It's used by all the community team, but also it's sort of evolved into the workings of what we call it the therapist centre. So we actually use the complexity framework with the patients that are coming into the day centre as well, because we've recognised those patients and their complexities of change, and it's about how we capture and manage those patients as well. From each face-to-face assessment and to MDT discussion, when we case find, we're using all the things that are really listed up there, and we agree what the red flag and what the complex situations are. The case manage, the complexity framework starts really when we do an immediate face-to-face assessment. We agree when we discuss, and we discuss how we facilitate care at home.
So very briefly, so you don't just start with red and work your way through green. So you refer as routine or urgent to us, and we don't have triage system that can say thank you to Sheffield's healthcare community, and we take the referral. So urgent ones go to our rapid response team, routine will get Steve in zone, hopefully within a few days, 5 days is our standard the team has got. The rapid response is same day or next day. Patient preference, appointments, things get in the way of that, but appropriately so. Okay? So you could have somebody you see at home who is, you could describe things stable, you've got IPA scores of 3 or 4, the dog getting methadone, they've got uncles homeless. We've got a series of broad red flags which also highlight to us that we're going to have a particular set of actions as well, a number of management points. So you can start in red, and our hope is that even if you've got a tracheostomy, a PIC line and a TPM, 2 syringe drivers, if you can get that set of problems less complex, enable your GP and district nurse, whichever healthcare providers are in there, and actually you can move into a phase where we can just titrate, monitor, liaise, create more bespoke plans, and perhaps into green where we're literally touching base, keeping in contact with you, and preparing to hand over to the GP and district nurse if that's what's appropriate. Okay? You can also come into our team just as a routine referral, and some people see you obviously you've got complex problems.
I think working sort of pre-framework for us, it's given us something to sort of hang how we case manage. I think, before as a CNS within the team, I can say this, you would just slot your patient in, whatever that referral said, you would just slot and find a space in your diary. This has allowed us really to be more fluid. We can address patients who are red a lot quicker. We're not waiting for the next available slot, which may be 2-3 weeks. 2 weeks our nurses used to like, wasn't it? And also for the sort of management plan as well, we didn't just have that 2-week follow-up. We had a reason, and what gave us a reason why we needed to go back, like within 1 day, 2 days. So this is just a case scenario which sort of describes how we use the complexity framework. So this was a patient who was referred to us by I would say a very competent GP. In Sheffield we have quite a cross-section of GPs who have varying knowledge and skill set in palliative care. This patient was seen by a GP. He was a 27-year-old with a rectal cancer. He was referred to us routinely. He'd been in surgery, and the GP had rung up for us to go out and see him for pain control. He was on methadone for substance misuse. When we spoke to Mum, they confirmed that we needed to go out and see him at home. The complexity framework starts when we actually go and see and have eyes on that patient. And actually what we saw in front of us was a young man with a poor performance status. He'd got a very large fungating rectal tumour. He wasn't able to sit, stand, he wasn't able to sleep because of the pain. He was just kneeling by the side of it was his mum's hospital bed. She's got her own health problems and wasn't able to get upstairs. It was septic, he'd got a lot of discharge. He was actively misusing his drugs. He got a poor understanding of the drugs that he'd been prescribed. He couldn't read or write, and he was HIV positive.
So you would describe Craig as unstable. He reported to his high ankle scores. And perhaps our red flag situations have evolved for us to not produce a result, but actually to say, there are a number of things I need to deal with as a healthcare professional. I have a number of actions I need to carry out. Then we can outline, we've got a series of them, and if I handed you out the competitive framework today, say that's really nice, but actually what does that mean to me? So it'll mean different things in different areas, but we need complex medications, substance misuse, it might be multi-morbidity, other healthcare problems going on. He was at high risk of bleed, he was septic, he had an early bowel obstruction at that point, and had very complex psychosocial issues. I could talk about Craig all day because he took a lot of our skills. So we had 2 of us on that visit, and unfortunately it was 2 doctors. So Joe was back at base delegating. It's me and my registrar, and we started to get Craig comfortable, get them a plan, establish expectations in the moment, and a series of treatment on a number of levels. I escalated and discussed it with my senior team member, because I can't do all of those things that Joe has the skills to do. This is why we are working in this integrated way. In the house, we were able to carry out specialist prescribing, supporting medicines management, and we liaised with about 20 people from my memory, and then we came back, talked to the team in our huddle, we agreed it was highly complex and red. There were a number of ongoing live issues. Next day we talked about it at our rapid response huddle, and out went, not me or the registrar, but one of our specialist nurses with a version plan. With our ongoing daily visits, we were able to facilitate admission for him. He was absolutely terrified. One of the reasons he was in this pickle is a very poor word to use at this stage, because he was terrified of hospitals and doctors and nurses, and he DNA'd all his appointments for lots of complex reasons. So it's making broad sense at the moment. So we're going out to see people, we're getting incredible information from the patient-focused outcome measures from our specialist assessment. We do have the added bonus of delegation going on, using our reshift tool, we've got assessments on it and ankles in it. But essentially, at the point we see Craig, we're delegating to, if I wasn't there, Samurai would be consulted with, or Joe, that's the level of input we've got that day. Measures, and they're using the complexity framework to articulate and communicate about what's going on. We come back to a board round, the whole team's there, they're discussing all their complex patients they've seen that day. Then the delegator keeps a really close eye on this, so all the team come back in. It takes about half an hour, sometimes an hour. It's less if we've got more on delegation. We then have a morning huddle, which is rapid response, and we discuss the urgent patients, the new to us, the rapid response, complex, highly complex patients. And then we also have our weekly MDTs to confirm plans, management, and also how we currently describe complexity.
So this is just a snapshot of September's and our caseload at the moment. So you can just see we've got 445 active patients on the caseload for September, and this just sort of divides it up. So, and this is fluid, it changes every day, every week, but at the moment we had 187 referrals, 99 of which are routine, 68 with urgent. Over the summer, I think the urgent referrals were actually more than what the routine referrals were. We had a total of 542 visits, and rapid response visits were 181, and that's over a 7-day service. So you can just see the pie chart at the moment, it just gives you a visual of what the RAD rating looks like for the caseload at the moment. Team diaries, it makes us, the complexity framework makes us, our approach to work a lot different to what it used to be. It makes us more flexible and responsive. We have a visual, all the team now work out in a zone. So we don't just have one nurse who is out in one area. We may have, we've got 3 teams. We have 3 or 4 nurses who are out in each team. So the patients, GPs, district nurses know they may get a different face when they visit. We try for continuity, but sometimes because of how we work, it means that with a RAG rating in a zone, the band 6 will have overall view on the patients. The band 5s don't actually hold the caseload. The caseload is held by the band 6. But with us we have all the visits on our Outlook diaries, which are red, amber, green. So if things are changing daily, I have a really good view on the diaries of, what the caseload is looking like at the moment. Medics aren't pre-booked. Generally. We ask for medic intervention either through delegation, because Laura or Sam can come on and consult on through delegation, or we have these discussions on our daily board round or MDT. I think that's it, really.
So talk about senior team members. I mean, myself, the registrar, and team members like Joe, examiners, prescribers, they're experienced team members. And there are a number of roles. So I talked earlier on, didn't I, about sort of classic consulting model and how we have our weekly diary described. Actually, there are a number of quite fluid things we need to take part in now with the way that we're working. So we might be doing rapid response visiting on the day or next day. Often joint visits. I was really excited by Stephen Rice's slides this morning. I was like, clearly I don't visit anymore. I do. I still need doctor in the team, but I'm doing other things. So I'm doing other things. So we've got our MDTs, we've got being present at the morning huddle and board round, being integrated, having influence, having review, learning together. Also delegation, sort of that active importing to about 30 visits a day. And we're also available for escalation and consultation during the day. So that's a bit where we also think we're becoming integrated with our nursing colleagues and being available to each other. And instead of Craig's visit, I couldn't have done that visit really without having Joe back at base and got through all that sort of rapid management plan in the face of all that complexity. So these are not randomised controlled trials conclusions. We've asked the team about this. This is what we think we do at the moment with the way that we're working. Okay? So we think we manage the complex situations in front of us with most senior team members most of the time. Okay? We rapidly assess, individually manage, we think we reduce complexity, we certainly see, as we've heard described this morning, alpha scores reducing, phase changing, and we improve symptoms and communicate that with all involved. Okay? We achieve the birthplace of death. I can't remember the numbers now, do you understand? But yes, it's good. But we also, I said to the team in the next room, we avoid unplanned emergency admissions. What we try to do actively is to plan, yes? Planned emergency admissions I'm happy with because people are going in for an intervention. Sometimes people are choosing to go in for sepsis bundle management, so into a within an hour, get your antibiotics, have 24 48 hours, come back over normals. We communicate well with that hospital team, with the senior registrar, it happens and it works, and they come back to us. Okay? We can also arrange things like those Western Park admissions going, we can then go to the assessment centres for their MRIs, for their sepsis management, for the cancer care centre. And the Hampshire ones, which is more neuro.
Urology? Urology. Hematology, yeah.
So, for the clinical team, we think we're able to respond flexibly, we educate and role model for team members. We take a lot of feedback, but we're also in a place where we can give feedback as well. Okay, the team will take feedback. We agree and deliver on clinical standards, so the aim of directly improving patient and carers experience. That's easy to say, hard to deliver, isn't it? But we think we're doing that. We do debate and readjust dependent on team pressures. So Sam described at some points we've had 7 or 8 nurses, and that's a bit, isn't it?
Risk. Bit brisk.
Yeah, bit risk. We put ourselves under pressure to deliver to our high standards, it gets riskier, but it's achievable. We've also started, I think, with this, because we could describe with some expertise what's going on and our response. We're doing lots and lots of jobs. We're more confidently liaise with people, so we're more confidently ask the specialist in the hospital or the GP knows the patient very well, what do you think about what we're doing? What part are you going to play? My favourite visit with one of the GPs last year was when he said, you can do your funny stuff with funny medicines and I'll just do normal general practice. I said, thank you, that's very good. That's best feedback I've had in ages. But he was describing, I think, a bit where what we want to be doing is supporting district nurses and GPs at home in what they don't usually do. Does that make sense to everybody? So we're hoping that this way of prescribing, of working, helps us deliver that. So we go very briefly through these numbers. They're not very interesting, they're very, loads of interest to me. This is very the competitive frameworks. This was just about the time we're about to start with iPods and all changes. And the majority of the time the consultant's going out after a nurse has been to see, but very quickly. So our opinion was on that. So we're going out same day or next day to the highly complex patients as we're currently describing them. With some fairly limited time, so quite a lot of visits. Over 40 weeks, maybe sort of 6 to 8 visits. That was hard work, but it was done. And we tried to ask the question, did the medic, as a proxy for somebody go to see highly complex people, really see highly complex people to describe it? And we do. The registrar saw a lot more of what turned out to be amber patients, so a lot more titration monitoring. It was actually the consultant was directed in the way we defined it to red patients. And medics carried out a bit of activity. I took myself in a second for a person, so but I think I was surprised. I thought I was doing a lot of medication prescribing. I didn't quite realise how much sort of psychosocial complexity we were starting to deal with, support the team with, support the district GPs and COPD mental care team and the Huntington's team, which was a big thing for me when I first year here. And the palliative emergencies, I've learned a lot. It's stretched my medical abilities. I'm now sepsis bundle doctor. I'm now bowel obstruction doctor. You know, the things you learn about what you need to learn yourself during this process are quite amazing. Very briefly, this is the old sort of set of red flags that we have at this time. Okay, so you've heard us say we're using phase, we're using icons. For some reason, we found ourselves describing this consistently, didn't we? So you saw the previous slide that 40% was complex physical, but the whole workload we carried out. 15% was palliative care emergencies managed at home, not usually managed by GP district nurse alone. But there's variance in that, depending, as Joe described, on the confidence, availability of the GPs and their teams, and complex psychosocial. So complex physical symptoms that respond to first-line treatment, a little bit like the patients you might see in outpatients, but these patients can't get to outpatients. This is kind of new work. Okay, does that make sense? Complex neuropathic to one of the opioid agents. We had a professor here who was quite fond of combination opioids. Yeah, so I had a lot of patients in the community on combination opioids, 2 or 3, and there's a lot of team learning about how we manage that and do that together. Methadone or ketamine patients, I and the team will use either because people have come out of it, methadone or ketamine at home or have used it before. We've upskilled the team for a lot of learning, got some governance in place. It does require medic leadership, I say that.
There you are.
Yeah. Assessment following procedure, and the palliative care emergencies are the growing area, so acute deterioration with no plan. And certainly if you find yourself becoming more responsive, responding to urgent situations, responding to phone calls, you go out and find really cool sick people, so you've got to upskill and understand what your series of treatments are for disabilities. And the big area was this, and if you're, and correct me if I'm wrong, if you're working in a hospice, as Dr. Taylor described this morning, you have a whole team around you, don't you? Amazing social workers, skilled healthcare, skilled nurses, and you can form a big team. A lot of this is learning with the GPs. We've had some different processes in Sheffield, haven't we? Lots of early mental capacity assessment, nightmares, that can really bring people together. So it was a whole load of key work. And I think we only describe this work because we're delivering on it because we have limited resources and we wanted to work in this integrated, responsive, flexible and excellent way. So, as I said, I'm not handing out a copy of what we do because what we do may not be right for everybody else. Increased data from Professor Lenton team might influence, and we might end up saying we don't need the red flags. We might actually be able to work in a way together as a whole team, case finding, case managing. But what we're hoping today this afternoon is to use the expertise learning experience today to look at what we've done, is it right, is it wrong, the better ways of doing it, and to update and define the current version and plan further research in pilot, which is easy to say then, so this
I must ask a question, which comes out of this really, which is, when people go for red, amber or green, is it easy for them to agree? Because the case you presented was highly complex. I don't think any of us would disagree that it was red.
Exactly.
But I just wondered if there were ones that you found very borderline and you didn't know whether to make them red or amber or amber or green.
They're called Rambo. We call them Rambo,
Call them
don't
Rambo.
we? Yeah. Yeah, we have a lot of discussion about that.
Rambo, again.
Yeah.
So to help everybody, we're not being flippant about it because there is debate at these edges. I mean, nurses like you saw 6% amber and I go, you know, that can't be right. Must be all be getting better. But actually, there's a bit of debate, and I say to the nurses, if you don't have a plan, you're doing all these things without you're doing all this work, that patient's red and highly complex, and you need to take credit for the work you're doing. But also, they know that we'll get them at the board round.
Yeah.
That sounds
So
terrible.
do you tend to go for red in that support? Which way would you go?
I'd go for the descriptor. So when we've got case managed, it's quite detailed. So if you're having to carry out a lot of the, when you first meet somebody, you've got a lot of liaison. So when we did the medic numbers, about 20% of my time, including visit, was spent on the expert liaison. So that bit of your management of highly complex patients, which requires a great deal of expertise and input, and it's that case management bit, which is intensive. Does that make sense? So that's why I say please take credit for that. It's a way of us managing our work. And so, do we ask patients and families if they think they're highly complex?
I was just wondering if another point is that's the purpose of the MD team, and that's the purpose of the board round. What you're doing is you're gathering professionals together, and although someone's got to be the final decision, you're looking at them really, the team are there, and the team will get a sense from each other whether it's red, amber or green. That's the function of bringing the objective measures in the IPAWS into that context. You know, if someone is scoring mild on the IPAWS right the way through, and you know, and they're describing it as amber because they want to go back and see them in 8 days, and you can't say, really?
Do you tell the patients whether they're red, amber or green?
No, not
Have you thought about that?
No, not to be mentioned it. Not knowing me, so yes, we perhaps do. Yeah, well, there's a bit. We perhaps do second-handedly, if you like. So when the team go out, if it's not me going out, I would go out and say, I'm a member of the team. Your seems a bit complicated. And try and get it all better for you. You may not see me again. The team members may come back. I can come back at any point. Me as a representation of the red person today, seeing different people. And we introduced that concept of the right person so we can see you right from the beginning. I've heard Dave Jones, one of our senior team members, he has a nice passage which I wish I could copy. But he said, you've seen it today, you might see a team in the next week, but I'm going to sit with you and my team until we get things better. So it's sort of a proxy way of saying it, a second-hand way, but we don't describe it.
No, it's not the right words, is it?
Yeah.
So,
Can we just ask, how do you do your huddle versus your gorge work? Just describe it a bit more detail.
So the huddle in the morning is purely the sort of rapid response team. So they will look at all the referrals that have come in overnight or first thing in the morning, and we'll talk through sort of all the sort of urgent referrals that come in, because the way that we work now is, you know, going back, you know, we used to have a bit of resistance from nurses. They go, oh, no, they're amber, because if we made them red, it means they need intervention 3 times a week, and they'd be looking at the diaries thinking, oh my God, when am I going to fit that in? So that's why, yeah, 2 people, 2 weeks, no, it's not, it's red. And that's why we introduced the rapid response team, to be able to sort of escalate things up. So if people have got people in their zone, you know, caseload who suddenly become red, they go into the rapid response pot. Now, some of the nurses will say, I'll take that red patient because I want to do that because I've been on this journey, but some of them will say, actually, I've really not got capacity to move anything today, and it'll go into the rapid response team. And that's where we have the huddle, because it isn't just referrals that are coming in, new referrals, it's also sort of existing patients within our caseload. And that is every day. And think, you know, when you go in and you put your phone up and things have gone horribly wrong for a certain person, that comes into that morning huddle. The board round is where all the team members, Laura, Sam, the registrar are present, and we talk about not just the rapid response team, but the zone patients as well, all the sort of red, the new patients that we've seen that day, and also the ones that are sort of a change of phase or scores 3 or 4 on their IPOSs. So that's how it's. I call it, and we have had a bit of resistance to this, but this is just like a handover. So instead of sort of the old way of working, when I first came to the team, I had my caseload. Nobody else touched it. Even when I went on holiday for 2 weeks, nobody picked my phone up. So I just had to pray that it was all okay. To now that every patient is visible across the whole caseload. It's because the teams rotate onto the weekends to cover rapid response. So everybody has a view on, everybody has a knowledge of all the complex patients within the team.
You talked about urgent. So have you defined urgent on your referral forms?
No.
Because for me, that patient up there would have been urgent.
Yeah.
Routine.
I think we're looking at introducing our own internal, because what we find is I mean,
everybody would think urgent.
well, the thing what's happened is because they know we've got this rapid response team is now, and I know, you know, like certain clinics what turn out on a Friday afternoon, I'll get 6 urgent referrals from that one clinic because it's Friday afternoon. And what our urgent is, we have a very different, you know, indicators to what other people's urgents are.
So we don't advertise that urgent at this point.
We're about to pilot a triage based on what we've learned about ourselves,
Yeah.
and we'll see how that goes. At the moment, in the healthcare community of Sheffield, I was a urgent routine, and you have a good sense of doing it, but we want to make it a bit more robust and reproducible and try that.
Can I just ask, I know this is about response, but do you see all your referrals in the community, or do you bring any up to the hospice?
We did have a community clinic what we're just re-looking at, so we do, yeah, we had a colonoscopy score. If they were 60 or above and they were able to get to the hospice, we have seen people up at the hospice. Because for me, not everybody wants to wait for me to rock up late. And
this is what I just want, sorry, because I appreciate you looking
So I'm not just about hopefully doing something like spot clinics, so it can be 5 days a week, but that responsiveness when you bring somebody up, you know, actually I'm going to Western Park for my radiotherapy because my pain is awful, but they can make it up that afternoon. And so I've done seen at home.
Yeah. No, that makes sense to me.
but there's nurses, doctors present in those clinics. It's just, yeah, it mixes.
Can I just ask? Sorry. So we've had this your service frequency.
No, because the complexity doesn't go away at the weekend for us. We just have reduced numbers, so we don't have all the zone working out there. We're just dealing with the red patients. So, you know, we've gone from 1 nurse being on to 2 nurses being on to now we have a delegator and 2 nurses on the field. And looking at the way we are at the minute, I'd like to have 3 nurses out in the field, 1 delegator, because, you know, the resource just gets sucked away as we put it in. So we have on-call medic and also consultant advice as well over at a weekend. So it's just that the numbers of the team are smaller. We just do the urgent work at the weekend.
Also, very as you mentioned there, do they start to say for yellow health conditions? Do they get called out for the urgent?
So this is, I think this is part of my new role because I've sort of taken on the HP services as part of our integration. So occasionally they do, sort of wellbeing will go out and see patients, but that's a whole new...
So an example of one scenario we had was somebody who's been seen by an enablement team, which has physical problems, but our physio was going further advice to me, and about 5, didn't he? We went out and gave her sort of a little personal plan for moving into the shower basically, which she did go to, and she did doing more lessons, and we made it work in a similar way like to do to a hospital setting. But the work we're kind of really interested in is we add value of slope stuff, so what we get in the community now is a very responsive set of routines, physio, so actually what the expertise brings is a little bit like you described what medicine nurses do with my complexity. We have a sense, don't we, what the chaplain is doing with my complexity, physio, social workers, so it's a really exciting area to think about. We've hopefully got the opportunity to start looking at that.
I think one of the biggest balance issues is that whereas it's much more complex in the community setting because it's multi-agency, and so, you know, the physiotherapy and occupational therapy and psychology are provided by other services, and the key for us also is thinking about how we integrate, how we activate them appropriately. So I guess it's the complexity framework. It might be in the future we might imagine that we might be leveraging for the green and ambers where it's an AHP related problem. That might be where we leverage the community service where we know the kind of response we get. But if it's something that's, as Laura's describing, that's particularly complex, we need to think about how we might leverage our own team. Can these patients come into our active intervention centre? Those are the challenges. It's just we don't have the resource, or haven't historically had the resource to have a team of HPs going in.
Is your rapid response team, is that flexible from within the wider team? Do you define rapid response, or have you got a definitive rapid response team that's separate to your wider team?
So we've got a definitive rapid response team that work Monday to Friday. At the weekends, we have other team members rotating into that, which is good for them. They learn how to deal with acute situations a little bit differently to the zone working.
So then your zone workers then are picking up the amber and the green and the regular caseload, or how?
So
Like a case that when you look at the numbers, they might start out with a non-urgent referral, but then they will still walk in the door and find someone who's high complex and have to deal with it. So their numbers are lower in terms of the whole month, but their patients will go up and down in the first picture.
So the zone teams are geographically based. The rapid response team cover the whole of the city, and they can be from where I've been, Stocksbridge to Mossborough, depending where the red patients are.
And have you got skills within the rapid response team, or is that just you?
Yeah, we have. I mean, we've got prescribers, examiners, predominantly in that team, but we have got people who are starting their journey on their prescribing courses and APAC courses. So, but that's something that we want the whole team, that skill set, to have. That's whether they're in zone or rapid response. Pardon? We've got band 5s and 6s, and we'll have a band 4 who will be working out with rapid response. So we're starting next month.
Day-to-day basis, sorry.
All right.
Your rapid response team, how many would work within your team?
We have 3 and the registrar, Laura, so it varies.
Or, 7 or 6s?
6s and 6s.
How do you acquire the iPod and Technology? It seems as if you were getting that from when you're having your meetings beforehand. Is it from the assessment?
We do face-to-face, yeah.
I do every visit, every face-to-face contact we do.
And is that, so if somebody's got like a routine assessment, so
Yeah.
that they're and agree,
Yeah.
might that be posted out to the patient?
No.
It's always...
What we try and do is, what I try to encourage them to do, what I do is I'll go out and do my initial assessment, and then I'll leave a form and say, would you mind filling me that in next time I come? Sometimes they do, sometimes they don't. Obviously, depending on how the patient is, if they're too unwell. Yeah, because the team go out with either laptops or tablets, they actually may get the patient to sit, if they're able, to do it on the tablet while they're there. So, yeah.
Yeah, so we hope to describe to you how we work. Our complex environment has grown and certainly accelerated the use of absolute measures, but describe our integrated team, responsive and flexible, and hopefully demonstrate some of our expertise.
Okay.